Thanks, Clinton. That was great. Really good overview. I hope everyone found that useful. I certainly did. So we've had some good questions actually. So thank you to those of you who have popped some questions in. I'm going to just spread these around the panel actually. So we've got probably one question area for each speaker, if you like. So I'll take the easy one. Which is from Sarah. I presume that's Sarah Morgan in Wales, who's our meso CNS in Wales, asking about whether the Predict Meso study that I mentioned is going to open in Wales, and it is. We're setting up Newport at the moment, Sarah, and we'll probably look to set up other sites in Wales, and there'll be 25 sites across the UK. Now we've got another question around gender in mesothelioma. So this is maybe one for Selena. So Selena, the question has come from, do we have a name on this? No, no name. So my grandmother had and died of mesothelioma, having contracted it in probably an munitions factory in World War II. And my mum has now been diagnosed. We think possibly exposure to asbestos through the father's work clothes and things. Are you seeing more females diagnosed with secondary exposures?
Thanks for the question, Kevin. So we definitely are seeing more females being diagnosed with mesothelioma. I would say that often it is from, like you mentioned, secondary exposures where it's been the partner, the father, who's directly worked with asbestos and perhaps brought work clothes back. But I think we're also increasingly aware of low-level exposures in certain workplaces. Teachers, administrative staff in certain environments that can over a longer time be exposed to asbestos, and we are seeing some patients with that. And I think in the break we're going to be hearing from a video on the GEMS study, which was a study done sponsored by Meso UK, done with the Sheffield group, looking at gendered experiences in mesothelioma. So hopefully we'll get more details from that, and for those that are continuing on with us through to the break. But yes.
Yeah, great. There's a good segue into that little video item. So, Clinton, there's a couple of questions been popped in around some practicalities around immunotherapy. So, one, again, there's no name on this, but it is someone describing their mum who's become Addisonian on nivolumab and IPI. Looks like we can getting treatment in Edinburgh. How often are we seeing this? And the follow-up is just to say that the patient is actually doing really well, a bit like you'd said, side effects are not always a disaster. Patient is feeling reasonably well, quality of life's improved, but just curious as to how often we see those sorts of side effects.
Well, certainly we can extrapolate a lot from our lung cancer experience as well too, and this is not uncommon at all. I wish I could give you an exact percentage. It's not a high percentage, but it is very much manageable as the patient's mum's doing. So again, that's the importance of what we will do in terms of monitoring patients. They'll all have cortisol levels checked. If a patient's very unwell and the blood pressure is very low and they present to A&E, things like that, like checking the cortisol is very, very important. So again, the replacement therapy, once that starts, it's very easy to continue and continue with the plan of delivering immunotherapy, because this is purely replacement therapy. Again, quite similar to what we see with hypothyroidism, the replacement utilizing thyroxine. So sorry I don't have an exact figure for you, but it's not very uncommon, certainly from the lung perspective, because it's still early days for us in treating mesothelioma with ipi/nivo. I'm certainly sure that as time goes on and we start using more of it, we'll be able to audit our own real world practices, but it's going to happen. It's going to happen, and we need to look out for it, and we need to monitor patients very carefully.
Yeah. So that's really helpful. So I think Clinton's point's a good one. It's just a new thing for mesothelioma. So that's one of the challenges I hinted at, is actually how we implement this across Scotland, and we do it nice and efficiently so that we're all up to speed with these things, both patients and the doctors looking after them. And Clinton, just a follow-up was around a question around the 2 years of nivolumab and ipi that we have from the SMC approval, and why is that 2 years, and what happens at 2 years? What would you expect to happen in your patients at 2 years? Would you be coming off at that point? You know, is there a weaning process? How do you foresee that going?
Yes, it's a good question. Again, you know, even amongst oncologists, we talk about this, and we've talked about it too for lung cancer. But you know, the license is 2 years, so that's the license we're given, and we're very grateful we have that license. Obviously, the trial was 2 years, and at 2 years, again, from my own personal experiences with lung cancer, if a patient's done very well to get to that 2 years. And you know, there are going to be risk of ongoing toxicities beyond 2 years. I personally would have a discussion of saying, look, you've had the 2 years. I think we should call it a day and simply continue to monitor you carefully, monitor your bloods for a period of time. It would be several months. Patients still need to be monitored at that 2 years and beyond, because you can see immunotherapy toxicity even come in or start months after finishing immunotherapy. So I think it's something that we'll probably come back and rediscuss amongst the specialist groups. But in terms of me being able to say you could be allowed to go on beyond 2 years, we can't say that. The license is for 2 years, and the aim is to get as much treatment in and get the benefit of the treatment, but be monitored again to beyond that.
Okay, that's great, Clinton. And another thing to say, I guess, is it's not a static environment. You know, if you start immunotherapy this week, in 2 years' time, we might have some more proven therapies in the second line. So because there is so much activity of other drugs being evaluated. So I think that's been really useful. We've been through the kind of question themes that we've got there. I think we should probably give people the comfort break we promised them. And have a wee break before the next session. So I want to thank Clinton and Selena for their talks. They were really valuable, and particularly thank Joe. I think that was a really brave and very informative discussion of his own situation, and I'm certainly very grateful to him for that. So we're going to have a video playing during the comfort break when you can go make a cup of tea, or just sit and watch it, which describes the gender experience in mesothelioma study. And then we'll come back to the second session, which is going to be chaired again by Selena. So she is working for her money this afternoon, and that's going to be on support and legal services. So I'll hand over to the break, and hope you enjoy the rest of the afternoon.